We acknowledge the traditional owners of the land on which this podcast was recorded, the Wurundjeri Woiwurrung and Boonwurrung peoples of the Kulin Nation, and pay our respects to their elders, past, present, and future. Welcome to the podcast series of Raising the Bar Melbourne, curated by the Faculty of Medicine, Dentistry and Health Sciences at the University of Melbourne. This special health edition of Raising the Bar, held in May of 2026, featured 20 talks by some of Melbourne's leading healthcare experts and was held across 10 pubs and bars, all in one night. The speakers presented topics ranging from AI and cancer research to understanding ADHD and neurodiversity, helping kids sleep, healthy social media habits, the future of robotic surgery, and much more. In this episode, you'll hear Professor Ben Dixon and Dr. Renu Eapen talk about how robotic surgery is reshaping operating theatres, enabling safer, less invasive, and more personalised care for patients and clinicians.
Lovely to be here. I was a little humbled to get the invitation, and when I did get the invitation, I was a bit worried about how I was going to spend an hour up here talking about robotics. And then I remembered that I had a surgical colleague who not only does robotic surgery, but also has her own podcast. So I thought she would be the perfect co-host. So thank you to Renu. Little round of applause.
I think we were at a tennis event, Ben, and I'd probably had a couple of drinks and didn't know what I was saying yes to. And the next thing I know, I'm roped into this.
You're here.
But it's a great topic, so I'm very happy to be here.
Yeah. So I'm just going to start with disclosures about what we do. So I use the Da Vinci system, which is a robotic system, and Renu uses the same robot. So I have no financial interest in the company at all. I have travelled to learn robotic surgery and do mentor some surgeons who are using the device, and that's sort of funded to an extent, but I'm certainly not on the payroll, and I have no particular financial interest in.
Yeah, I'm the same. Big robot enthusiast, but no other, nothing else to gain from it.
And I think that's probably pretty important when we're talking about medical technology, because there are a lot of people out there that are involved and investing in companies to build this stuff, and have a sort of way of thinking about it that might be a little different. The other thing I want to disclose is, and I think I can speak with both of us, we're clinical practice surgeons. We both do research, but we're not engineers, we're not data scientists, we're not computing people, we're not AI experts, we're not robotic engineers. So we can answer questions in regard to being surgeons and using this technology, but don't come at us with too many really technical questions about robots. I think you'd agree with that.
Yeah, nothing too hard.
Yeah. Just want to start with we're going to ask a few questions of the audience and keep it pretty interactive. But first of all, I'd just like to know how many people here are in the healthcare industry. Just hands up. So
quite a few.
Small-ish number, but quite a few in healthcare. How many in sort of computer science, engineering, robotics type thing? A couple, and a few that are not disclosing any of those interests. So that's good to know. Just sort of the audience we're talking to tonight.
Is there anyone else that uses a robot, does robotic surgery in the audience? I didn't recognise anyone else, but great. Good to know.
So Renu, why do you use the robot in surgery?
Yeah, I mean, that's a good question, isn't it? I think nowadays in neurology, I don't think you have much of a choice. It's a technology that's kind of hit us, and neurology kind of has been the success story in robotics, I think. During my training, I was trained only really in open surgery and laparoscopy, so the robotic technology was really just getting started in Australia. We only had access in the private sector, so when we trained through the public system, we had really no experience with it at all. And it was when I went overseas to the US to do my oncology fellowship that I first started to get some experience with it.
Yeah.
And I wouldn't go back. It's the advantages that it offers is significant. Just the magnification, the view, the ergonomics. It reduces surgeon fatigue. I'm quite a petite person, and one of our bread and butter operations is a prostatectomy. And a prostate is probably the most well hidden organ in the human body. And I still remember standing there with my mentors, surgeons, who kind of put their hand in there and go and say a few things. I'm here, I'm at the apex, here it is, and all of a sudden out comes the prostate, and you have no idea what just happened. So the ability to train well and view all the steps is just a game changer. So for so many reasons, I think the robot has really changed the way that we practice urology.
And it does really help assistants and surgeons learn when you've got that immersed 3D in the robot console. But also the ability for everyone in the operating theatre to be able to see it on a screen, whereas in open surgery and some of the older forms of surgery, it was difficult to know what the surgeon was doing.
Yeah.
So can you tell us a little bit about what type of operations you do with a robot? So you mentioned prostatectomy. That's probably the most bread and butter. Robotic surgery done in Australia. What other operations?
So when it comes to prostate surgery, there's the prostatectomy for cancer. But we can also do kind of what we call simple prostatectomy, which is taking out the middle part of the prostate. So that's just for benign enlargement of the prostate gland. So that's probably all the prostate surgery. We do a lot of kidney surgery, so removal of all or part of the kidney. Reconstruction of the kidney, a lot of bladder surgery, removal of the bladder, reconstruction of the bladder. And now there are new things that we used to do very well open that people are starting to do robotically, and that's a bit of a fine line. I always think when you are talking about doing something robotically that you've done open or laparoscopically in the past, you have to ask yourself, how does it make the operation better, either for the surgeon or for the patient? So that's an important consideration. I think with prostate and kidney surgery, it absolutely makes it better. Mm-hmm. But that's not the case with everything.
Yeah. So I'm at the opposite end of the body. I'm in the head and neck. So
really the opposite.
Renu's down the bottom. I'm up the top. We never meet, other than the operating theatre, tea room and those sort of things, but not for combined cases very often. But robotic surgery for me is mostly through the mouth. So we're able to go in through the mouth with a surgical robot and then operate out from the mouth rather than going in externally through the neck. And there's some pesky structures in the head and neck region, like the jaw and the voice box and all of these sort of things that people like kept intact. And it allows us to get inside, take a tumour out without having to disrupt some of those structures and keep people able to use their voice, their tongue, talking, breathing, eating. Everyone likes doing these things a little bit more easily without some of the additional access issues we have. So it's really revolutionised for myself, for usually tonsil and tongue-based cancers, and some tumours that are out the side wall of the throat, sort of wedged in between the skull base, the jaw and the throat. And that's one of the more common tumours I do. It's a very rare tumour though. So there's only a couple of people in Melbourne that do a lot of head and neck robotic surgery, whereas for urology, it's really, it's becoming almost, would you say, standard of care? Would most surgeons coming through for urology now be expected to do robotics?
Yeah, especially if you're in the oncology field. There's lots of other aspects of urology where the robotics doesn't have as much of an impact, but definitely for oncology, so for cancer work, it's the way of the world, like it or not. Most people that are newly minted surgeons will have only trained in robotics. It's the other end of the problem that we're now facing is open surgery and laparoscopic surgery they're kind of ancient ghosts.
Yeah. And we'll touch on that, de-skilling of older style operations a little bit later as well.
The other thing I see in my field sometimes is that even though there are lots of procedures that we do endoscopically, so this is through natural orifices, so we might go through the urethra to take out a bladder tumor or to take out a bladder stone or even to take out a kidney stone. There is robotic technology that's being encompassed into these procedures as well. This is something that's quite exciting. It's not going to make it any more minimally invasive, but it does mean that the quality in which we're able to treat these conditions can improve.
Yeah. Great. So you get the patient, they're off to sleep. You put the robot into the patient and you press play. Is that right? Is that what you do? Tell us about the process. Then it just takes over? Or?
It should be. And you won't believe how many patients are wheeled into the operating room for their prostate removal, and they're just about to go to sleep, and they'll ask me, where's the robot? And I point to this big thing, right? The boom of the robot where the arms are attached. And I said, that's it. But I expected a little robot man.
Yes.
So
don't expect a humanoid robot. And we might come to that a bit later as well.
We still have to do a bit of work.
Yeah. So can you explain it? So it's a master-slave system. So it basically, you control it remotely, but usually in the same room, and it goes where you tell it to go. And so there's no autonomous features of it at all. It doesn't. So it's not really a robot. But in our minds, it's a robot because it's sort of a remote control surgery. But it does allow us to get to some places and operate where otherwise we would have a lot of trouble. That is, we can see around corners, we can manipulate around corners, and we can put instruments that are that we can flex with wrists. And with some of the newer robots also elbows, and we can actually use wristed movement around corners, and we can scale it down and take out any tremor. So taking out tumours out of small areas, and we've got tight access, we can actually get in there with a smaller incision or less access procedures to get in there.
And when you compare it to laparoscopic surgery, it allows you, just the ergonomics are so much better. So if in laparoscopic surgery, if you're turning like that to do a suture, that's it. That's the limit of your hand movement. But with the robot, you can just go back and turn it a little bit more. So it's just that ability to have complete 360-degree a kind of movement of the wrist just means that you can do so much that is very limiting in laparoscopic surgery.
Yeah. And that clutching, we call it, is something that takes a little while to get used to, doesn't it? Because you can do a movement and then you can press a clutch and then you can move your hand to wherever you want it and it doesn't move the instrument, and then re-engage the instrument and do it again.
That's insane.
And that is something that you can't do. The other thing I find is I can have an assistant helping me, so I cannot be operating in the mouth, and I can have 3 instruments and a camera and have another surgeon at the bedside with 2 instruments, so we can have all of that operating at once through the mouth. Now, if you try and do that with a headlight and clunky old straight instruments, it just doesn't happen. So we can operate around corners, see around corners, but also have 4 or 5 instruments operating at once, which is really revolutionary. We can't do that with old style, especially in a small orifice or
and
likewise.
No, you don't rely on someone to hold a camera for you. Everything is, so many more things are under your own control, which is fantastic.
So you've had used some of the earlier generation robots, and we're moving through to the more modern ones. Can you tell us some of the changes?
Yeah, this is a really rapidly evolving field. So one company has kind of has monopolized this industry for the better part of 3-4 decades, and that's Intuitive, which makes the Da Vinci robot. And we've seen several several generations of the Da Vinci robot. When I started out in the US, it was the SI, which is the standard instrument, a standardized robot, and it was very good. That's all we had, so it was fantastic. But we moved to the XI, which means that the ergonomics of the arms are a little bit better. When we used the original robot, we had to be very careful when we put all the arms in that we would target that organ, and if that kind of moved a little bit, it would make the instruments a little bit more clunky, and you have to be very careful how we place the ports. They have to be equidistant, you have to triangulate them. But the XI removed all of that. It was very forgiving. If you put the ports in a little bit further out or closer together, it wouldn't matter. The instrument would just forgive that. And then we moved to what we call the DV5 robot, which is the latest. The XI is very good. I always thought it was very hard to improve on the XI, but it turns out, you can get like a phone charging port and I don't know, like cup holders and, the console head that kind of moves with your head. And, and once you experience that new generation of robot, it's then very hard to go back. So I think the XI, so the second generation compared to the first generation had a lot of improvements just for the patient. I think moving on to further generations now, it's focusing on the surgeon. and making sure that their comfort is optimized. And also you get a lot of feedback on how your metrics are doing over time.
Yeah.
Intuitive have also introduced the single port robot, which, Ben, you have a lot to do with. When we got the first one in Australia at the Epworth hospital, and that's again, no need to put multiple ports in. You do it all through one port, which makes sense for your specialty.
Yeah, so
you already have one port.
I was always given a robot that was designed to work in an abdomen with multiple ports going into an abdomen that could be blown up with gas to make a big potential space. We can't do that in the mouth. We can't make it much bigger. We make it pretty big when you're asleep, with some gags that we put in to open up the mouth, but there's limitations. So trying to get multiple ports into the mouth and then get multiple robots' arms into the mouth was pretty difficult for us. So now there's a new single port robot where it goes in through one tube that's about that thick, and it goes in and it springs out into multiple instruments. So you get 3 instruments that can move in terms of cutting and grasping instruments. But also a camera that's on like a little snake, and it does a little cobra movement, and it can look around corners. So for when you've got a limited space to work in, it allows you a few different options, but also I could get 3 arms in then, which I couldn't do with the multi-port, because I just couldn't get 4 ports, because you need 1 for the camera. So I couldn't get 4 of these ports into the mouth. They just do not fit in anyone's mouth. So it allows us some extra flexibility there, and that's certainly the way. Hopefully the way the future is, we've got more options for what we can use for surgery, because it's not all designed around, laparoscopic style surgery or surgery where we can inflate the abdomen. And there are some for example, in prostate, you can do it single port and have a smaller incision or less access.
Smaller incision, and the access is completely different. So the unique thing about urology is most of the organs that we deal with are not actually in the abdominal cavity. They're outside. So they're kind of in the back of the abdomen. We call it the retroperitoneum or the extraperitoneum. And this single port robot has the ability, normally with the robot, we would go through the abdomen to get to these organs, but now we can kind of skip the abdomen altogether and go through the back into these tight spaces and take out tumors and take out prostates. And it just means that if a patient has had a lot of previous abdominal surgery, that we see those patients who've got kind of the battle scar wounds. We can expect a lot of scar tissue in there, and then you need bowel surgeons to help you kind of navigate all of that. We can bypass all of that and kind of sneak into that area where the organ truly is, and kind of get the work done.
And so there is currently, as Renu's just said, there's one dominant company. There's a few other companies that have robots that are somewhat useful, but there are, the last time I checked, over 110 companies worldwide that are trying to make surgical robots. So this is a huge area, and not all of them will be successful, but some of them will, and hopefully we'll have more competition and some cheaper prices going forward. You were just in China and got to see some of the technology over there. What did you witness?
Technology in China is just amazing. I mean, they've got their own little ecosystem. It's their own planet. So, of course, they've got their own version of everything, which is amazing. But there is a company called Microport that actually makes a robot that is very similar to the Da Vinci robot, but it is a lot cheaper. So I went to the Microport kind of headquarters in Shanghai, and it's like visiting Google. It's amazing, they've got their own restaurants, their own hotels, sleeping pods, and you look at the variety of robots that they have. They've got hair transplant robots, and I kind of got a behind the scenes look into the factory and how things are assembled, and we see the kind of the whole process from the making of the individual components to putting it all together and to testing it and to retesting it. And then finally it's in this big crate, and that's the assembled robot. So, I mean, it's the fascinating process of how this thing is created and built. Microport is definitely gaining more popularity, and I think we'll see that robot in Australia just because it is so much cheaper than the Intuitive one.
Yep.
But there's Japanese ones, there's Indian robots. I mean, the market is really saturated now, but just time will tell about the quality of this and whether it stands the test of time like the Intuitive robot has done.
Yeah, and it's difficult for a hospital to make a decision whether you go for the tried and true to have got reps on the ground and can turn up and who who they are, but it costs $4 million to buy the robot versus buying a cheaper one, but you don't know whether it's going to be, whether the company's going to go bust in 2 months, whether they're going to have local support, whether you're going to be able to use it, whether something's going to break. And we'll talk about that in a little while as well. So for people who don't do robotic surgery, which is most of the audience, it's good to think about in terms of levels of automation a little bit what it's like when you're with self-driving cars. So there were some predictions that we'd all be in self-driving cars by now, and we'll touch on some future predictions a bit later on as well.
They're there in China.
But yeah, there are self-driving cars certainly available, but there are levels of automation in cars, or levels of how much of what you would call it a robot, from completely autonomous through to what we see as lane assist or adaptive cruise control and those sort of things that most people will get some idea of from a normal car that you drive on the road at the moment. And then but along that continuity, as it becomes, it's difficult to know. Where does that, and it's difficult in designing cars, where does the automated features in a car switch over to a driver? And where does it happen with a surgeon as well? So if there is any automated function, which bits do they do, which bits does the surgeon do, and where do you draw the line of where that happens? And we were just discussing earlier, we have registrars, trainees, we teach the surgery, and we're all almost doing that every day, aren't we? Conditional automation. They can operate as long as we're happy that they're operating, and as soon as they're not, we're like, we take the controls. It's going to be a little bit difficult doing it with a machine. What do you think?
Yeah, I think so. I mean, and surgery especially, because there's so much nuance to it. I even though I see a lot of things becoming more and more automated, I can't envision the day when it will completely be automated. Because I've never seen two prostates that are the same. I've never seen two people with the same renal anatomy. So we have to get to a point where we can account for all of this. So I agree. At the moment, it's definitely a conditional automation.
Yeah. And it's interesting, there's a lot of focus on automating one part of the process of surgery, which is usually some really technical little bit. But when we think about it, there's a lot of human encounters all the way from when you enter a hospital on the day of your surgery till you leave. You come in and you check in with someone at the desk. You don't do that on a computer or a kiosk. There might be some pre-check-in you do online, but you still see people. You see people for pre-operative checks to check your allergies, go through a whole checklist. Anyone here who has had an operation will know how many times you're checked. You are who you are, what your allergies are, you've got your labels on, you've gone through the process, you're definitely here for that operation, you're appropriately consented, and then you have anaesthetic and an anaesthetist, anaesthetic nurse, we have techs within the operating theatre. Moving someone who's got complex medical problems with lines and tubes and whatever in from a bed onto an operating table is a big procedure. You have multiple people watching, communicating, working together. Then you've got your sterile equipment. That's sterilized by someone who's putting trays in and out, counting trays. The recovery room, then going home, making sure you're recovered well enough to step out the door. And that's even if you're just a day surgery. So for some reason, we're trying to replace with a robot one little technical stitching thing where there's room for improvement in reducing the number of humans required along that entire system. So I always find it interesting that there's so many companies just really wanting to sew a piece of bowel together better. When humans sew it together pretty well. We don't have huge failures every day with that, and often it's a judgment failure or a system failure rather than a technical failure when we do have these complications. Would you?
It's such an important point, Ben, because I do agree. I mean, the actual surgery itself is such a small part of that patient's journey. I mean, it starts at the time that a surgeon decides to operate on the patient and decides that's the best thing for this patient. So that initial judgment call all the way to their recovery and getting home from that episode. Yeah. I mean, there's no point in doing a fantastic robotic surgery if it's done on the wrong patient or the wrong side or for the wrong reason, right? So all of those things are very human aspects of caring for a patient and doing an operation on a patient.
So you've got a bit of an idea of what we do and what we do in our practice and a bit about robotic surgery. So we're gonna be a bit more interactive for the rest and ask you a few questions about where you stand on some of these topics. So if you can imagine you or one of your loved ones has got a tumour, and you're going to need surgery for this tumour, and you're going to need to find a good surgeon. And you go and see two very respected surgeons. The first one says, I do this operation robotically. I've been using it a lot lately. I think it offers all these advantages, A, B, C, and D. I wouldn't do it any other way, and I think it's the way to go. Then you go to surgeon B, and surgeon B says, I've done this 1,000 times. I use my tried and true method, and I know my results and they're good, and I don't believe in all that robot stuff. I don't believe in it. And then you have to go home and make that decision. You need the operation, or your loved one needs the operation, and you just have to go over it in your head about what sort of choice you're going to make. Now, just thinking about it, just put yourself in that scenario. How many people think they'll go with surgeon A, who offers the robotic technique, or surgeon B? So how many hands up for surgeon A offering a newer technique? How many for surgeon B, who says, I've done it 1,000 times, tried and true, know my results? He's a true
expert,
yeah. There's a couple, and and there will be people who say, I believe that person has done it 1,000 times, and it will actually come down to your connection with them and whether you actually trust that they're saying what they're saying. But these are interactions that we have all the time, aren't they? There's some people who come to us for an opinion. We say we'd go down this pathway, but this person said this, and people look for second opinions. So
what would you choose, Ben?
I'd be very careful about a surgeon that operated on me. But
no.
I'd certainly be going for, you want a surgeon who does the operation really well. You want a good surgeon with existing technology more so than you want a bad or even average surgeon with a shiny new robot.
Yeah,
okay, so I think that's really important.
I totally agree. I don't think the robot or robotic technology will ever compensate for surgical skill and knowledge.
Yep.
You give a robot to someone who doesn't appreciate surgical planes and they can get into all sorts of trouble.
Yeah.
But at the same time, you do want someone who does embrace new technology, because this surgeon who's been doing the same open technique for 20 years may not know that there's this great technology out there that could accentuate and enhance his or her skills. So I agree. I think you have to choose wisely.
And there's an incredible amount of bias that goes into your head, and you've seen in the media in regard to this. So there are a couple of things. There are the bias that you don't want to miss out on what the best treatment could be, or if something goes wrong and you went with the other treatment, could the robotic surgery have saved me? Then there's a halo effect around the robot as well. Robots can do no harm. There's an automation and a technology bias. We feel that using technology or any automation or newer things is just going to be better. There's also the novelty factor, the marketing, the media. People don't care if I do a non-robotic surgery, but people seem to care if I do it. The same operation robotically is somehow news. So there really is that effect there. And then there's another one known as the prestige bias. So what's the prestige bias in this?
I got a robotic vasectomy.
Yeah, yes, exactly. So you do get this the same way some people choose the designer handbag to carry their stuff around. You get
Professor Dixon did a robotic
surgery on me, and people will show off with that sort of thing. So there is a prestige effect with the robot and the technology as well. So there's all these things that that go into people making these decisions that aren't necessarily that are a bias, and there's a lot of bias towards technology and towards newer techniques and things that are seen as more fancy, newer, just a shiny new thing. And question.
Changes would you suggest to the manufacturers that they make to their products, and do they seek your advice on those things?
We might touch on that a little bit later, but they do seek our advice. So the question was whether they seek our advice on changes. But they're really tricky things to design, surgical robots. So has anyone in the audience? Next question. Ever had any sort of digital technology device that's frozen on them or stopped working?
No way.
Put your hand up if something's ever frozen.
Come on, every hand should be up.
So
who hasn't?
So who hasn't? Everyone has had some sort of digital device that's just suddenly stopped working, or you have to turn it off and turn it back on. That couldn't possibly happen with a surgical robot, could it, Renu?
It does happen.
Yeah.
It's like any technology. I mean, the chances of it failing suddenly are less. But this is part of what you're asking. What kind of improvements have been made in the past, and this is part of that continuous improvement process. It's because things go wrong that we know what needs to be fixed. But yeah, it's like anything. You do have these robots that freeze in the middle, arms that stop moving. We use this energy to buzz through blood vessels that stops working.
Sometimes the arms just have a technical error and you have to take it out and get another one from so open
every now and then
one,
there's
so
this automated voice that goes, the Da Vinci is running on battery, and I always freak out. I think, well, what if the battery runs out? Plug it in. For sure, all these things can happen, which actually is a problem in our world, because the easy things, fixable things are fixable, but if the robot suddenly just stops working and you cannot proceed, you have to have some way of treating this patient. You can't bail out in the middle of an operation like you can do with lots of other technological things. So what is the alternative? What's the backup?
And this is an issue as we bring in more robots, more technology, and that we've seen this in quite a number of other surgeries where newer techniques have taken over from older techniques, but you still need the old techniques every now and then. And then how do you train the next generation of surgeons who have only ever done it robotically if there is a failure, or if there is a problem, or if there's a catastrophic event where you have to open up and fix something? How do you train that? And it's something we have to, year on year, as we're evolving and doing newer techniques, have to think about in how we train our juniors who may not, ever see an open prostatectomy. Possibly?
Yeah, absolutely. Yeah. I mean, I would say they're extremely rare now. If you can't do a robotic prostatectomy, that patient would end up getting radiation. That's how far we've come. In
this robot you're using, that wouldn't be attached, to the internet at all, would it? No one could actually get in there and use your robot. It's a closed system within the operating theatre.
You'd like to think so, but I don't think that's the case.
Yeah, it could be hacked. Case. Yeah, so it is connected to the internet while we're operating. There is data streaming to the US. What movements we make and what happens. So, and this is a very, there's some. So the DV5 robot that you mentioned, the company have said, well, we've got 20,000 times, I think it's 20,000 computing power with this robot. Now that 20,000 times computing power is mainly for them to get the data from us rather than to really help us, correct? That's the feeling from surgeons?
Oh, for sure. It's such a marketing gimmick. Yeah. But, they tell us, you can get all your stats back and, see how your time has changed from case to case, and, how much time you spent on the clutch, or, your efficiency of movement. But, it's all this data that's being stored by the company. Who owns this data? What's it going to be used for? If it got into the wrong hands, what would be the implications? These are serious concerns as we move ahead in this technology.
And we see hacking all the time. And who's to say that our internet connected device that we're doing an operation on isn't going to be hacked? And there could be a time in the future where the majority of operating theatres have got robots and possibly a lot of autonomous surgery going on. Let's say 15, 20 years time, that might be the case. There's those in the audience, and I might get a poll shortly, that might think that's going to be sooner. But what happens if there is some sort of cyber attack and all your operations just shut down in the place? How do we have the contingency there to actually complete those operations safely, or at least get the patients off the table safely? Who's around? Who's checking? How do we prepare for that? And is anyone doing that at the moment?
Yeah, I mean, I don't think there's an answer to that question. I think it's going to be a big problem for us, and one that we are going to have to answer to.
Yeah. So Elon Musk, he says, don't go to medical school.
Not worth it. Don't waste your time.
He says humanoid robots will surpass human surgeons in 3 to 5 years. So just I want to get an idea of how positive people here are on the future and how soon you think this will happen. But who thinks here in, say, 2030, 4 or 5 years time, you're going to have a domestic humanoid robot in your house doing the chores? Hands up for anyone who thinks that they will. Some early adopters may well, but what about 10 years later, 2040, you'll have a humanoid robot. Yeah. Does it have, it's a really good question.
Wow,
There's quite a few people who think, no, it doesn't need to be humanoid. In fact, humanoids barking down the wrong tree. We're not going to have humanoid robots. We'll have more better designed robots for the tasks they need to be doing.
Absolutely.
So, but there are also people such as Elon Musk who says we will not need surgeons eventually, and in 3 to 5 years we'll have robots that are better than surgeons. Again, thinking of all those tasks, do you think Elon's read the College of Surgeons surgical competency list?
Judgment and clinical decision making is not top on that list.
Yeah. So there's just to explain on that, the College of Surgeons has a checklist of 9 different areas of of where we need to
proficiencies that you have to,
and the technical proficiency of one of 9 things, and a lot of the things are making good decisions, having good clinical knowledge, good judgment, good communication, working in teams and collaborating. There's a whole lot of other things that go into becoming a surgeon rather than just being able to do a nice stitch. So I think there's a lot there that probably isn't considered when you're looking at that. Now, sure, AI robots could learn that fairly well, but it's just a matter of how soon we think that's going to happen and how soon that's going to come out. And there'll be certainly people that think that's inevitable. I'm not sure it's going to happen in the near future. Keeping in mind that Elon Musk also said in 2024 he'd have a human on Mars and we'd all be in robot taxis by now, and you could have trips around the moon in 2018. So he hasn't been always right. Sure, he's done a lot of stuff, but he hasn't been always right on this stuff. And I think it's a little bit it's unlikely from my perspective that we're going to be seeing humanoid robots doing surgery within 4 or 5 years. But I guess watch this space. But there's a few health economic concerns and access concerns to getting humanoid robots in every operating theatre in Melbourne. Do you have any idea how many operating theatres there are in Melbourne?
Gosh, there's a lot.
Hundreds. Yeah. And so it would be a lot of new technology to bring into hospitals.
Especially because we're just starting to get these robots in public hospitals. I mean, that's only just happening.
Yeah, and this is 20 years in the making, really. A lot of these.
We do have a long way to go.
Robotic operations were popularised around probably 2005, maybe a little bit earlier than that for prostate, maybe. But yeah, it's sort of been 20 years of it being popularised, and now we're only just seeing public hospitals starting to put in robotic systems, which are becoming more common now. So
I think we should ask them. I mean, who thinks that it's still worthwhile studying medicine and becoming a doctor and a surgeon? Hands up for yes.
Yeah. So if you had a colleague, a friend, son or daughter that said, "I want to be a surgeon," you'd still think that's a good career going forward in the next 30 years? Yeah, most people are nodding.
What's that? Except for the stress.
The stress, yeah. Well, hopefully technology
can
take
look
some
too
stress
stressed, right?
out of it. So complications occur in surgery. We know that, and we know that they're going to be inevitable no matter who and what is doing it. Who's responsible if there's any automation within the surgery? I mean, at the moment, we are very much responsible for what that machine does, and everything is tied to our movements and what we do with it. There still are some things, as you talked about, with it freezing or causing a problem or an arm not working, which can create a problem for us that's technology driven, but we're still ultimately responsible for it. But as it starts operating, or as robots could operate in an automated fashion, who's responsible for complications?
Yeah, I mean, it's a good question. I don't have the answer to this. And if we do a bit of future gazing and think about, say, telesurgery, right? Someone in Australia is operating on someone in India, and this happens. This is. I mean, we see it as part of conferences all the time. And the first telesurgery was done just a few years ago, and it was a general surgical procedure. And the first prostatectomy done in Beijing. From Bordeaux, when we were at this conference seeing live surgery, with tiny delay times. It was amazing. But, if the robot breaks down in Beijing, which indemnity is going to cover that? Is it the surgeons? You know, where does the surgeon get their insurance? You know, who takes responsibility for this? I mean, it's a real issue. And again, I think we are going to have some guidelines on this going forward when we do more of this.
It's hard enough for us to go across town to another hospital that we don't already operate up to get credentialed.
Yeah.
And we have to go through all of these
there's no way you could touch a patient. Yeah.
So it's really difficult. There's a lot of credentialing that goes into doctors. There's obviously insurance. There's a whole lot of layers of things. There's a lot of systems that need to be happy in hospital governance, in professional colleges as well, and obviously indemnity. And they're going to do their risk assessments in any of this automated procedures. So I think there are a lot of those barriers that are going to be there that need to be tackled long after we've got technology to actually physically do the surgery.
Yeah.
I think we've probably gone over time already, and I know there's probably hopefully be some questions from the audience. Anything else you want to mention about the future or where it's going? We could talk about the future of robotic surgery.
Yeah, surgery in space. That's robotic technology makes that possible, or at least conceivable. But again, all these barriers are definitely there. One thing I think that robotic surgery really helps is training. Right, the ability to be able to train people in remote locations to do this procedure, to train our trainees who are in the operating room with us. It's so much more rewarding than when we did open surgery, because you could just see what you're doing.
Yeah, and we have these dual console robots, so we've got it's like having two steering wheels essentially, and you can switch out from one to the other, and so you can have a trainee operating on the robot. And not only you can do that, you can draw pictures on the screen that they can see of where you want them to cut or what you want them to do, and then erase them out again, which I find really annoying when someone that does that while I'm trying to operate. And also, they've got the full 3D immersion and can see everything, and you can take back the instruments and stop them from operating straight away and do it yourself or show them. And so that's something that you really can't have in any other type of surgery when you're learning.
And even if you're an established surgeon trying to learn a new technique that's done on the other side of the world, you can have a mentor log in from that location and still guide you through the procedure. So the implications for learning is enormous, and that's why I think it's still a fantastic time to be a surgeon, and it will continue to be so.
Well, thanks. Ben and Renu, I think you displayed all those 9 proficiencies of surgeons, so congratulations. I mean, some of that content was mind-boggling. I actually haven't had the privilege of hearing surgeons talk like that. Is that how you chat in the tea room? You mentioned that.
We dumb it down between ourselves.
So we have some time. We have a reasonable amount of time for questions, so fire away.
Hi. I guess I'm really interested in knowing about the regulations that actually currently exist. So you've mentioned there's been a lot of rapid development, like you've seen already like 3 or 4 iterations of the Da Vinci robot in your own career. I guess what are the current existing regulations, whether it's an international global regulation, whether it's country dependent, training requirements, I guess, like the engineering risk assessments as well that currently exist to bring these robots into hospitals?
Yeah, it's a really good question. There's no one worldwide regulation, so it's different, not just in every country, but in every hospital. Yeah. So normally when a really new technology hits us, so like the single port robot when it came, surgeons would have to do some dry lab training, so simulations using the technology, and then they would need to go and do a wet lab. Somewhere in the world. So there are areas around the world that they have this established, the company has established, and so you would need to go and do that. And then what we did at Epworth, where we got the first robot, is we had a proctor come over from the US who had a lot of experience, and he would spend a few days here guiding people through their first surgeries. And so and now when a new surgeon wants to get credentialed with the single port robot, we would say he has to do simulation training and he has to have a number of cases proctored and signed off. But that's a really good question. Ben, what's your take on it?
Yeah, it's a really difficult topic, and one of the reasons why there's all these robotic companies and a lot of them fail is not the actual product itself, it's getting it into the market, going through all these checks and balances. And they go, as you say, all the way down to hospital credentialing and those surgeons that are in the hospital having to take some responsibility. So we have robotic committees who sort of will oversee who gets credentialing rights to be able to use that for that operation, looking at what training they've done, what background they've done, whether they're up to date on that equipment and signed off by the company. It brings in surgical companies as well into the credentialing, which it gets a bit murky because they want people to be using their technology. So we've got to also have checks and balances from more of a society and a hospital side. When I say society, professional society, and a hospital credentialing format to make sure that we've got the checks and balances and it's not the company just wanting everyone to use it. So we'll credential everyone to use our robot. So it is really tricky. And then there's different laws for Australia versus other companies for medical devices, and it's a really huge area, and I don't think I have the expertise
so
or
much
time to
happens
touch
before
on
it
that.
even gets to the using it. And it's not, remember, it's not just surgeons, it's also nurses and assistants who make, who are really integral to the cases.
How many robotic surgeries have you performed, and out of those, how many did you have to intervene where the robot failed?
My head and neck's a fairly small volume compared to a lot of the prostate stuff, but I've done about 300 robotic cases on head and neck stuff. I've had issues, it's probably 1%. Okay, it's probably two or three times, and most of them have been very minor. Something freezes, and it's usually something that we've done, manoeuvred or something, and it's just caused an error or a clash, and the clash has been to an extent where it's shut down. There's other ones where the cord's faulty, the arm's faulty, or whatever, and it usually recognises that straight away, and then you have to go and get another one. So there's the minor ones, and then there's the ones that happen during an operation where it just stops for a reason. There are other brands of robot that people have stopped using. We won't name names, but have moved away from or stopped using or refused to use because of the number of times that it does have issues. I've
had a couple of instances. Both have been kidney surgery. So kidney surgery is kind of high stakes because you've got these big blood vessels to the kidney, and if one of them bleeds, you don't have a lot of time before you can salvage the situation, and that usually means opening in a hurry. So I've had to do ones for bleeding, and ones because we just weren't progressing, and the tumor was just too difficult to get into it with the robot. So and the bleeding one it's a quick conversion. So the assistant this is where the bedside team becomes so crucial. They have to get the arms out, robot back, and start making a slash, right? So it's time critical. So that's why that team is so important. And in thoracics it would be the same. They would have a known protocol for how to convert these cases to open, because you have to do it in a rush.
And it's they're big machines to get out of the way. You can't get in there and operate while they're there. You can't operate around it. You have to take it all out and then get all your other equipment in and get started on that. So it's not an easy process, and you need to be in a trained team to do that. Yeah.
You've spoken about the technology problems with robotic surgery. Are there any other drawbacks in comparison with open or laparoscopic? I'm thinking in particular in the Euro area where, as I understand it, the operations can take longer using a robot than if you did it open. I've had a radical cystectomy.
Cystectomy?
Radical.
Okay, yeah.
So, and I was told it'd take about 6 hours open and about 8 hours robotic, which is what it did take.
Yeah.
And that becomes an issue because the longer you're under, then you're more likely to get a pulmonary embolism amongst other things, and which is what happened in my case. So I was just wondering whether there's other things which, other than technology, we need to take into account when making a comparison. Also, the other thing is that, and I'm not arguing against robotic, I'd go down that path again, but the amount of feedback you get when doing sutures internally, you'd probably have much more feel if you're doing open.
Yeah, all good points. So to address your first question, you're right. There is a learning curve with robotic surgery. Someone who is able to do an open prostatectomy in an hour and a half, it's not going to be an hour and a half for the first few robot prostatectomies. There's definitely going to be a learning curve. So as you get through that learning curve, certainly your time reduces, and then everything is a risk-benefit thing, right? So then the benefits to the patient becomes a little more than the risks of a prolonged anesthetic. Having said that, when we're doing open robotic surgery, you're insufflating the abdomen. You've got the patient in almost a 90-degree head down, and that physiologically that can be quite a strain on a patient's heart and lungs. So assessing fitness for surgery is really key, and we do want to make sure these patients are going to be fit enough for the operation. Now, cystectomy is probably one of the most challenging operations robotically, and it's only now that people are starting to get into a situation where they can do it in a reasonable length of time. But if it can be done, then I think there are significant benefits to the patient in terms of the vision that the surgeon has, the ability to reduce blood loss, and most importantly, the recovery time from a big operation like that. What was your second question? The feedback, yes. You're absolutely right. There is no tactile feedback, but it is amazing how the human brain compensates for that. Would you agree, Ben?
Yeah, and that's something they're trying to build into newer systems of robotics, but it's still not great. So for soft tissue surgery, and when you're used to that needle, that suture material, and what it looks like, and that tissue that you're going through, you get an idea just by the visual feedback of what's happening.
And you can almost feel it. If you're putting a suture in and you're hitting bone, you can feel it. It's crazy, and your eyes are very attuned to tissue tension. I think all your other senses work overtime because you don't have that tactile feedback. That's a really good question.
But there are types of surgery, so it's good for soft tissue surgery, and soft tissue surgery where you can create room for your instruments. I do a lot of tumours in and around the skull base, the jaw, the cheekbone, the eye socket. And a lot of that is bone soft tissue junction dissection, so removing the soft tissues off the bone so you get to take out tumors or to work out where to make our bone cuts, etc. And the robot's not great for that because you just can't get that bone soft tissue junction without the right instrument. So the other thing to mention, the downside, is we've got 3 or 4 instruments we can use with the robot. Surgical trays just have hundreds, thousands of instruments that we can, so we've just got basically a knife and a fork and a spoon, essentially. Whereas the other surgical trays have got a lot. So there's some operations where it's just not appropriate. Now, we can do a lot with a limited range of instruments, but for operations where you need a wide range of different instruments, it definitely is not, we don't have the technology at the moment to be able to offer that. There's very few selections. And the other big downside is cost. And they're expensive machines. They cost millions of dollars. They cost thousands of dollars per case. There's no real, if you look at the cost per case of robotics, including how much it is to purchase the machine, very hard to make an economic argument on them. Most of the machines around Melbourne, up until sort of some government funding now, have been largely through philanthropy. And
hospitals often lose money with every robotic case. So, that's the biggest drawback and the biggest kind of thing that's factored into decision making to acquire a new robot.
Yeah. But it does help with, I suppose, the prestige you'll be seeing. I know I'm at St Vincent's Hospital, and we had an issue with surgical trainees from a very junior level wanting to actually come and train at the hospital because it felt that their feeling was St Vincent's was falling behind with technology. And so they've made a very definite investment in a number of surgical robots, as well as other equipment, to make sure we're up to date so that we're attracting not just able to do the state-of-the-art surgeries, but we're actually attracting the next generation of best surgeons through. So there's things by using newer technology, there's other benefits that you sort of don't think about.
Or getting a robot in a remote, like in a country location, it encourages more surgeons to go and work in those areas.
We've got time for just one last question. Just go ahead.
Just wanted to say thank you so much for such an insightful discussion as well. It's been really rich, kind of exploring some of those procurement-related sort of challenges, medico-legal related challenges and the use cases that you've identified. I guess I'm curious to understand, if you're talking about essentially robotic surgery being a loss leader for several hospitals, what does this mean for the hospitals in the rural and regional areas? And how can we continue to address those health inequities?
Yeah, I think that question goes well beyond robotic surgery into all types of surgeries, and encouraging the top specialists and doctors to provide services in those communities as well. And I think that's an ongoing challenge in terms of the equipment that you can use and the service you can offer in a rural or regional area versus what we can do in the city. But also just encouraging doctors to go out there and practice, and that's a huge area in my specialty. It's a big problem all around Australia, and it is with a lot of medical and surgical specialties. We have issues with a lot of people wanting to live in the city because they've lived here for their medical training. Their partner may work in the city as well, or may not want to move to a regional area. And then the technology side of things as well. If we can't offer those services in a regional area, that does put that community a little bit behind, and might mean that they have to travel to Melbourne or a bigger city to have it done. Or they may choose to have an operation in their local area, and we see this a lot. I don't want to come to Melbourne, I'll just have it with a local surgeon who may do very low volume or not have the adequate expertise or training to have it up to the high level that we want to have in our units we work on. This is going to be an ongoing challenge, and I don't think necessarily putting robots in regional areas will suddenly increase the quality of care. I think it's a really complex issue, and I think a lot of people are working on it at the moment, and it's the difficult problem.
Yeah, I mean, when you hear of places that get robots and it kind of just gathers dust in the corner because there are not enough skilled people to be able to operate it and do good operations on it. But inequity is a big problem, and if you think of it in a worldwide arena, then things like telesurgery is trying to solve that problem, at least in part, is trying to make robotic surgery accessible for people in areas where you wouldn't have that expertise, even if you have the money to buy a machine.
It's more than just the technology and being able to do the operation as well. You need entire teams around you to do this stuff. For head and neck cancer surgery, it's incredible the number of people we need. They're allied health. We have speech pathologists, dietitians, physiotherapists, really specialised nursing care. We have patients with tracheostomies and have free flap reconstructions in their mouth and throat. They need really specialised nursing care. They need a lot of input. Even if I could telesurgery it somewhere else, you'd still need that entire team. And that's another thing that's really difficult to replicate. And a small centre just can't have the volume to be able to sustain that.
Well, thanks once again for your questions, and thanks for your engagement. And a final round of applause for Ben and Renu.
Thank you.
Thank you for listening to the podcast series of Raising the Bar Melbourne, a special health edition. If you want to listen to more Raising the Bar talks, head to rtbevent.com/podcasts.